Good morning, everyone. It's my honor to speak today at Echo Rounds about a topic that's of personal interest to me, and hopefully it'll be helpful for everyone on the line. So today we'll be talking about echocardiography in the pregnant patient. I have no conflicts of interest to declare. The objectives for today's talk are to review the normal physiologic changes that occur in pregnancy, and then relate those physiologic changes to echocardiography and the normal findings that are seen in the pregnant patient. And we'll close today's talk by talking about a few select pathology that may be seen in the pregnant patient. So we'll get started by reviewing the normal physiologic changes associated with pregnancy. You know, these sort of graphs are published quite frequently, reviewing the physiologic changes that occur in pregnancy during the various stages in terms of changes in cardiac output, changes in heart rate, in systemic vascular resistance, and in blood pressure. Keeping things simple, just to summarize things briefly, as pregnancy progresses, there is generally increased cardiac output, and it's at its highest point when we get to the third trimester. Blood volume is expanded, systemic vascular resistance is reduced, and blood pressure in general is reduced. This tends to occur at the midpoint around 20 weeks gestation, but certainly starts to go up as the pregnant patient becomes closer to term. So looking at some of these factors in a little bit more detail, you know, cardiac output is needed to be increased in order to facilitate placental perfusion and meet the metabolic demands that are associated with pregnancy. And by the time the pregnant patient becomes near term, the cardiac output is increased 30 to 50% above baseline, up to 1.8 liters per minute above their pre-pregnancy cardiac output. And several factors contribute to the increased cardiac output, including increased heart rate. There's a hormone-mediated decrease in systemic vascular resistance as well as pulmonary vascular resistance. There's an increase in left ventricular mass, and there's increase in blood volume. And so just to have some numbers in your mind, heart rate tends to increase 10 to 30 beats per minute above the non-pregnant heart rate. And there was actually an interesting study that looked at sort of what is the vital sign range of normal for patients who are pregnant. And by term, the 97th percentile was 115 beats per minute. So that's a helpful, I think, number to keep in the back of your mind. A heart rate greater than 115 is quite high and should maybe prompt some investigation. And systemic vascular resistance is important to be decreased to, again, help facilitate placental perfusion. And this is hormonally mediated through prostacyclin and as well as nitric oxide efficiency. Blood volume also changes in pregnancy. So this occurs in a couple of ways. The red blood cell mass increases as early as the 4th week of pregnancy. It tends to peak around 28 and 34 weeks. And plasma volume also increases as well. And there's actually a net increase in plasma volume relative to the increase in red blood cell mass that creates this phenomenon called anemia of pregnancy. Pregnant women who do not display necessarily this anemia of pregnancy, which is just really a small dilution in the hematocrit, tend to, in observational studies, be associated with higher rates of complications. And the benefits of having this, increased blood volume, both from a red blood cell point of view, but also from just a plasma and fluids point of view, is there's decreased viscosity, which it helps to facilitate that placental perfusion. And it also creates a reserve in the case of blood loss that's associated with delivery, but also in the event of complications. It provides a reserve for the pregnant patient. And in terms of the timing of the changes, I think it's helpful to kind of frame that. In the first trimester, really the first kind of changes you're going to be seeing are progressive decreases in systemic vascular resistance. These are those hormonally mediated changes that decrease make the vasculature more compliant and allow for decreased resistance. And towards the second trimester, that decrease in systemic vascular resistance starts to plateau, and the cardiac output really starts to pick up at this point. And then in the third trimester, cardiac output tends to be at its peak. And that's, I think, going to be helpful to think about both for physiologic changes associated on the echo with pregnancy, but also with pathology. We tend to see issues towards that, that point between the second and the third trimester, around 28 weeks, because that's when the cardiac output tends to be around its highest. Heart rate, not surprisingly, peaks around that point. And it's also important to note that by this point, the uterus is quite gravid. And so when the patient is supine, compression of the IVC can occur, and that can reduce the preload that's applied to the heart, therefore decreasing the stroke volume. And that'll become relevant a little bit later. And then by the end of the third trimester, blood pressure tends to return to pre-pregnancy levels. In terms of labor and delivery and how the hemodynamics are affected there are multiple contributing factors around this point. Sympathetic drive can be increased by a variety of factors, including exertion, pain, anxiety, contractions, bleeding, and also, iatrogenic, what we do to the patients, right? Providing an epidural or analgesia can also reduce that sympathetic drive on the contrary. And cardiac output tends to increase, quite dramatically at this point. So from the already high cardiac output that occurs in the third trimester, another 15 to 25% increase is seen during labor, and during pushing it may be as high as 50% above that level. And the last thing I think that's helpful to know is that after the patient has delivered, the blood that was being delivered to the placenta becomes resorbed back, not completely, but for the most part, resorbed back into the patient. And this is a concept called autotransfusion, and this can dramatically increase their preload. It's helpful, I guess, in the setting of delivery to reduce the effects of drops of hemoglobin from normal bleeding. But it's also important to note that they may have this massive increase in preload, and that may affect pathology at this point in the pregnancy and this point in delivery. And then postpartum, these changes tend to resolve within weeks to months. We see normalization of the vasculature and the blood volumes, the heart rate, the stroke volume. So this is a helpful graph to summarize it and what I've talked about, and I think focusing on really that second and third trimester where we see a decrease in systemic vascular resistance, increases in cardiac output, will be helpful to understand the changes we see on echo. So moving to the second part of the talk, I'm going to speak about some principles of echocardiography in the pregnant patient, including some normal echocardiographic findings. So in terms of the approach for echocardiography in the pregnant patient, I reviewed a number of review articles on the subject, and in general, the approach is more or less the same, with the caveat that the subcostal window may not be achievable due to a gravid uterus. Not a hard and fast rule, but it may make it more difficult to access, and I'm sure our sonographers, have experience with this. In terms of the positioning, I found this MRI picture, which I found quite helpful to understand, the effects of the gravid uterus on the IVC and on the preload that would be delivered by the IVC. And so, keeping in mind that for the most part, patients are scanned in the left lateral decubitus position, this would help to actually offload the IVC. You can see in this picture when the patient's turned to the left, the IVC is much bigger. This would increase preload, and this affects loading conditions, and therefore could affect some parameters that we measure on echo. There hasn't been a lot of study in this, on this concept, but this is something that comes up. So I think it's really important. We do it anyways, but to report, the position the patient was scanned, as this would affect preload. And perhaps some of the findings we see on echo. And gestational age is also something to report to help provide context for the patient. So, a patient being scanned at, let's say, 13 weeks versus at 32 weeks, there's, as we talked about with the previous section, there's quite a big difference in their physiology. So that gestational age can be helpful to provide some context for the patient. And I did try to look into echo contrast agents and their safety in pregnancy, and this review article done in 2017 reviews in general the safety of contrast agents, but unfortunately there's no data in the use of these agents in the pregnant patient. So the recommendation from the various companies that produce these agents, as well as from these authors, was that, they should really not be used unless absolutely necessary, which has been what I found as well. These agents have been studied in the pediatric population with patients as young as age 9. There has been no, observed effects, but we don't have any data in the younger population, and certainly not in pregnancy. So, in terms of the echocardiographic findings in pregnancy, data regarding normal values is quite limited. There have been a series of studies which have.
Michael, I think someone's typing. It's quite loud. If everyone can mute, please.
Thanks, Dr. Connolly. Okay, we'll proceed. Hopefully that fixes it. So as I said, the data regarding normal values is quite limited, and that's because the vast majority of pregnancies do not require echo. But there have been some observational studies that have looked at what are the changes that we may see on echo. And again, I just stress that the different stages and loading conditions associated with pregnancy, not only affect the results in small ways, as we'll see, but can also make reporting and creating reference normal set of values challenging. So the first concept I want to talk about is chamber dilation. And in the patient, especially as they approach the end of the second trimester, that third trimester stage, as they get closer to term, we tend to see mild chamber dilation. And this study by Adyeye et al. In 2016, I think, shows this quite well. There have been many smaller studies prior to this, but I thought this study was quite excellent. So what they did is they looked at 100 pregnant patients. These were healthy patients, and they received echoes at their second trimester, their third trimester, and at the mid-third trimester. And then they took 100 healthy, non-pregnant age match controls. And so they basically enrolled patients as they knew they were pregnant and had progressed along, and these were the reference values. These are general as we see, not entirely unexpected. As pregnancy went on, weight tended to increase, BMI tended to increase, body surface area tended to increase. And I'll just pause here and say I tried to look into indexing and how we should be indexing the patient. Should we be indexing to their pre-pregnancy weight? Should we be indexing to their weight at the time of their echo? And I could not find clear guidance on that subject, and perhaps that's something we can discuss about at the end of the talk. Also, as observed, heart rate went up as pregnancy progressed compared to earlier on in pregnancy and compared to the later controls. So in terms of the chamber dilation, they looked at a lot of the classic measurements that we will measure. LA diameter and right atrial diameter were measured. They didn't measure areas or volumes in this study. But what they showed is that, for example, as pregnancy went along, the left ventricle tended to dilate. So from the reference value of 3.97 in the control non-pregnant population, in the second trimester, we started to see a little bit of dilation, 4.29, all the way up to 5.0 by the third trimester. And you'll note that these are still within the reference ranges of normal for a woman. However, this is a phenomenon that we'll see mild chamber dilation, both in the diastolic dimension. The left atrium also increased, statistically significant, though, you'll see that compared to the control, 2.78 plus minus 0.25 to 2.98. These are very small differences in the left atrium and in the right atrium size, but were statistically significant, and really just shows that the chamber dilation that occurs with pregnancy is quite mild and is quite subtle. They also looked at various parameters of, stroke volume and cardiac output, a lot of what we talked about in physiology, and I think it's great that, it confirms a lot of what is classically taught. in terms of increases in the stroke volume as the patient progressed within pregnancy, increases in the cardiac output as the patient progressed in pregnancy. And they found that, at least in this study, the left ventricular ejection fraction increased as pregnancy went along, which is not a consistent finding, and we'll talk about in a few slides. Lastly, they looked at left ventricular wall mass. And what they found is, in terms of measurements, the posterior wall tended to be increased as pregnancy went along. The septal thickening was increased as well as pregnancy went along, compared to earlier in pregnancy, as well as compared to the non-pregnant controls. The relative wall thickness, interestingly, was actually decreased compared to the control population. And the LV mass tended to increase as well. These are quite, significant drops, and these are not, the index or increases. Sorry, and these are the indexed values quite here. So, quite large increases in the LV mass. Hard to know how clinically, relevant any of these increases are, because for the most part, these are very small changes that are quite subtle. And certainly learning echo these past 6 months being a cardiology resident and learning more about measurements here, I can appreciate how a difference from 0.99 to 0.89 is quite small on when doing the measurements, but certainly it fits with the physiology associated with pregnancy. So to summarize, there's mild dilation of all 4 chambers. And this tends to represent a relative increase for the patients compared to their baseline, but again, they tend to be within the normal limits for an adult. The mechanism is likely increased plasma volume, and the chambers tend to return to pre-pregnancy sizes within weeks postpartum. In terms of valvular changes, so this is a study from Campos in 1993 that looked at 18 pregnant patients with serial echoes throughout their pregnancy, and then looked at 18 non-pregnant controls with similar BSA to the pre-pregnancy patient BSA. And then they found that there was a greater proportion of physiologic valvular regurgitation as pregnancy progressed, and it tended to be mostly right-sided. So for example, as they went along in pregnancy, if we focus on the gray hashed marks, we see increases in tricuspid regurgitation as pregnancy went along compared to the control population and compared to earlier in pregnancy. And similarly, pulmonic regurgitation is seen more commonly. I shouldn't say that these lesions increase in severity, because they don't. They're still these are very physiologic, mild changes, but they just become more apparent in pregnancy. Mitral regurgitation was also increased as pregnancy went along, though was less commonly seen than the right-sided regurgitations. And the postulated mechanism for this was likely due to, again, mild chamber dilation could increase your annular dilation or your annular diameter very slightly, and that may lead to increased physiologic regurgitation. And that's what they saw in the study, is that as pregnancy went along, we saw dilation in the atria and the ventricles in the various diameters. Interestingly, the aortic diameter was not increased in pregnancy, and I will say that I've looking at different sources, the aortic diameter may increase very slightly in pregnancy. In general, it should not increase significantly, and a finding of AI is abnormal. Compared to physiologic MR or TR or pulmonic regurgitation, aortic insufficiency shouldn't necessarily be seen in pregnancy, and so that finding would prompt some further thoughts and investigation. So again, if there's increase in physiologic regurgitation, they tend to be right-sided. AI is not normal, and these resolve within days to weeks postpartum. And as we'll talk about later on in the talk, pre-existing valvular disease may become more apparent in pregnancy due to those hemodynamic changes, including increase in blood flow and changes in diastolic filling times. And I'll say that RVSP in general shouldn't change in pregnancy. Even though there's more increased blood volume, the pulmonic resistance is reduced. And so in general, that should help offset the increase in blood volume, and our RVSP in general doesn't change. I'll talk a bit about left ventricular systolic diastolic function as well as strain. This is a study of 51 pregnant patients. They had echoes in their first trimester, second trimester, third trimester, and then postpartum, and they were compared to 10 control patients who were of similar age. They had not been pregnant, and they only had a baseline echo, and this was that control population. And so, busy table, but just focusing, your eyes on the ejection fraction. This study found that there was actually no difference in the ejection fraction. It found that, LV mass increased as pregnancy went along, which is what we saw in previous studies. They found that the diastolic dimensions increased, which is what we saw in previous studies, but the ejection fraction did not change as pregnancy went along. They also found that strain, however, by the third trimester tended to be reduced compared to earlier on in pregnancy and compared to the control population. So strain perhaps may be affected in the third trimester and perhaps slightly reduced compared to earlier on in pregnancy or in the postpartum setting. And there is some controversy in this domain, reading different review articles and reading primary sources. Some studies, as we saw with the study on chamber dilation, they showed that the left ventricular ejection fraction actually went up. The previous study showed that there was no change, and this study found that the LVEF went slightly down during the third trimester compared to postpartum, as well as compared to earlier on in pregnancy. You'll note that this value, obviously these confidence intervals, these error bars, are quite wide, but this average still falls between 50 and 60% range. And so even though there is a bit of controversy in terms of what happens with the ejection fraction in pregnancy, whatever changes occur are probably small and are unlikely to be clinically significant. In terms of diastolic function, again, another rather busy table, but just summarizing, the same study that we just talked about that showed a reduction in the ejection fraction very slightly, showed that when they looked at diastolic parameters, the E wave tended to be about 11% lower, the E prime tended to be about 8% lower, the left atrial area tended to be about 13% higher, and then the E to E prime ratio remained unchanged. And so again, these are really small values. Perhaps some of the diastolic parameters are slightly reduced in pregnancy. The clinical significance of this is unclear and honestly unlikely to be helpful, but just something to be aware of. So again, there's conflicting evidence in terms of the left ventricular systolic function in pregnancy. Does it go up? Does it go down? Does it stay the same? It probably stays the same. And any changes, outside of your normal sort of reference ranges would require more, thought and looking into. But small increases or decreases that still fall within the normal range are unlikely to be significant. LV strain tends to be reduced in the third trimester and normalizes in the postpartum setting. And then diastolic function may be slightly reduced, but again, unlikely to be clinically significant. Lastly, before we talk about some pathology, pericardial effusions. So trace to small pericardial effusions have been described in about 20 to 30% of healthy pregnancies. I thought this was quite high, but this reference, a study from 1990s, quoted these values. And they tend to occur as pregnancy goes on into the third trimester, and the mechanism is thought to be related to changes in total body volume. They looked at parameters such as hemoglobin or albumin. Did that change whether or not one was at risk of having a pericardial effusion? And they didn't. So just important to know that trace or small pericardial effusions may not entirely be uncommon in pregnancy. But effusions greater than small or persisting in the postpartum setting should require some additional thought and some workup. So to summarize, I like this table. This is an excellent review article, but I really like this table. So in general, ejection fraction, fractional shortening, your E to E prime ratio, your RVSPs, those shouldn't really be changed in pregnancy. we'll be seeing some mild chamber dilation. Certainly the LV mass and the cardiac output can be increased. The aortic and pulmonary VTI tend to be increased, probably due to increased flow, and then a pericardial effusion can also be normative in pregnancy. So lastly, I just want to talk about a few select pathology that may be seen in the pregnant patient on echo. And so the 4 pathologies I've chosen include peripartum cardiomyopathy. I'll talk a little bit about valvular disease. My colleague, Dr. Flora Huang, gave a recent talk on rheumatic heart disease and talked about mitral stenosis in pregnancy. So I'll only speak briefly on mitral stenosis and mitral valve prolapse, really just to illustrate the concepts of the hemodynamics that occur in pregnancy and why these lesions are important to think about. We'll spend some time on aortopathies in pregnancy, which I think are helpful topics to know for real life and also tend to be tested. And then I do want to talk a little bit about pre-eclampsia and some recent work that's been done on strain and patients who have had significant pre-eclampsia. These are the guidelines and statements that I've referenced for looking at these various pathologies. I thought they were excellent, the ESC guidelines, and then this recent AHA statement. So I'll talk a bit about peripartum cardiomyopathy. So it's defined as a new onset of cardiomyopathy with decreased left ventricular systolic function. The EF that tends to be referenced is less than 45% without a reversible cause. Presenting near the end of pregnancy or in the postpartum period. This is a picture. It's the apical 4-chamber. It's in the Mayo view of what peripartum cardiomyopathy may look like. The LV not always, but tends to be dilated. It's not a hard and fast rule, and there tends to be global hypokinesis of the left ventricle. Important to note that peripartum cardiomyopathy is a diagnosis of exclusion. It's important to rule out myocarditis, important to rule out hypertensive heart disease, really just making sure we're not missing anything reversible when treating the patient and not hinging on a diagnosis of peripartum cardiomyopathy. And mortality rates, with this condition have ranged quite significantly. In a Turkish study, they found as high as 24% of patients, and a German study was more 2 to 12% was their mortality range. So a significant morbidity and mortality can be associated with this condition. So one study I want to highlight is the IPAC study. This was a large study of patients with peripartum cardiomyopathy and looked at various factors involved in the severity and outcomes of these patients, and may help yield some important points when counseling patients. So the IPAC study looked at 100 women with peripartum cardiomyopathy that were followed with serial echoes in the postpartum year, and they basically had an echo at baseline, like when they were diagnosed. They had an echo at 6 months, and they had an echo at 12 months. And what they found is this is a figure from the study. What they found is that recovery of LV function really tended to occur in that first 6-month period. That 6-month echo was very helpful for gaining, some understanding about where these patients are going to land. And not as much recovery tended to occur in the 6-month to 12-month range. They also found that the initial echo or the initial LVEF on that first echo and the left ventricular and diastolic dimension, these factors were very important in terms of helping to understand about recovery. So when they stratified patients based on their initial left ventricular ejection fraction of either greater than 30% or less than 30%, you can see obviously they're starting from different baselines, but in terms of where they ended up landing in terms of recovery at that 6-month mark and at that 12-month 12-month mark were quite different. Obviously, you can see the difference in the gray lines between these two plots. There's much more patients that tended to be, thankfully, in the ejection fraction greater than 30%. But for those few that unfortunately had an EF initially less than 30%, their recovery tended to be stunted, and they did not, on average, tend to land within the an EF greater than 50%. Now, when they looked at chamber dilation, in particular left ventricular and diastolic dimension, an LV that was dilated tended to be associated with a lower probability of recovery. So as seen here, the patients who had an end-diastolic dimension of less than 6 tended to have higher recovery of the left ventricular ejection fraction, whereas, again, less gray lines here, fewer patients, but those unfortunate few tended to land in a much lower ejection fraction range. And then they looked at outcomes in terms of these patients, and not only they looked at whether or not the patient had an event. So the events they defined in this study were heart transplant, a VAD, or death. So obviously quite clinically significant events. Or an ejection fraction less than 35% was one of the groups they stratified. A second group was LVEF greater 35% to 49%, or an EF greater than 50%. And you see that if you had your initial echo and you were greater than 30%, recovery in general was good. 86% of this group tended to recover to greater than 50%. However, if your ejection fraction was less than 30%, requiring transplant, VAD, or even dying, was quite high. There's quite a significant proportion. So that first echo for these patients can be quite helpful in understanding what their trajectory will be later on. In terms of medical therapy for peripartum cardiomyopathy, the principles apply with general management of HFrEF, with some exceptions. Volume management is very important. If the patient is still pregnant at this time, diuretics will be important to decongest them, but important to keep in mind the status of the fetus, not to deplete the amniotic fluid too significantly. So, these patients will obviously be admitted. They will be followed regularly by the obstetric service and likely get scans very frequently. Afterload reduction is important for these patients, and I highlight nitrates and hydralazine typically because ACE inhibitors are contraindicated during pregnancy, and so these agents are the ones that tend to be used. But in a postpartum patient, an ACE inhibitor could be used. And then beta blockers or digoxin can also be considered. I won't spend a lot of time on this, but there's some interesting work on prolactin production and understanding, the mechanism for peripartum cardiomyopathy and why it tends to occur later in pregnancy or in the postpartum setting. And there's been some connection between prolactin and peripartum cardiomyopathy, and bromocriptine is through its effects on dopamine is an antagonist of prolactin. And there's been one study there's been actually a few studies on this, but the studies haven't been classically, your placebo RCT. They have been randomized control trials where patients have gotten different durations of bromocriptine, and they've then used that patient population and compared it to the IPAC cohort, and then saw were their outcomes better or worse if they were exposed to prolactin. So they're not perfect trials, but these trials have suggested that the use of bromocriptine improved LV recovery and had lower rates of some of those adverse events that we talked about. I know in Europe, use of bromocriptine tends to be higher. In the ESC guidelines, it's a 2B recommendation for bromocriptine use. Anecdotally, in Canada, we don't really use it. In attending some of Dr. Silverside's talks, I know she doesn't use it in the evidence, perhaps quite isn't there, and the EHA doesn't make any statement regarding this. But this may be something that may come up in the future as it's more greatly studied. In terms of risk in future pregnancy, so this is a review article from 2014, and the LV recovery, it's really predictive of what the future events will be in pregnancy. So these blue bars here are women who had an LVEF greater than 50% prior to their subsequent pregnancy. So they've recovered to an EF greater than 50%, and these pink bars are the patients who did not have an EF greater than 50%. They had an LVEF less than 50%, and then proceeded with a pregnancy. And you can see the rates of heart failure, the rates of decreased LV function, of persistent dysfunction, and death, particularly death, was not seen in patients who had LVEF recovery greater than 50%. That said, they still had high rates of persistent dysfunction. Their LV tended to decrease, and they tended to run into issues with heart failure. But at least in this study, they didn't die, but mortality rate was as high as 19% in patients who had an LVEF less than 50% and proceeded with a pregnancy. So I think it's very important, obviously, when counseling these patients. If their EF is less than 50%, pregnancy should really be avoided if possible. Obviously, the patient has a preference, but I think we have to counsel patients on this. There are some studies on stress echocardiography and strain analyses that in the future may yield some additional insights into how to risk stratify these patients as well. So moving on to valvular disease. Okay, it's not time. Some principles to understand is that increased heart rates lead to decreased diastolic filling, increased cardiac output leads to increased flow across valves, and the reduced systemic pulmonary vascular resistance improves flow, which is true for regurgitant lesions. If afterload is reduced, then the amount of flow going forward tends to be increased, the regurgitant volume tends to be decreased. But for stenotic lesions, they can't take advantage of that reduced systemic vascular resistance, and they tend to really be hampered by these decreased diastolic filling times that come with increased heart rate. So the general philosophy is that stenotic lesions are poorly tolerated in pregnancy, for these reasons, whereas the physiology of regurgitant lesions can actually be taken advantage of by the pregnancy hemodynamics. Briefly on mitral stenosis, it's the most common valvular disease of pregnancy, and rheumatic heart disease tends to be the most common etiology. And these patients, they may be asymptomatic and may not know that they have rheumatic heart disease until they become pregnant, and the hemodynamics of pregnancy tend to unmask it. The heart rate goes up, the diastolic filling times go down, and they run into issues with pulmonary edema or pulmonary hypertension. And heart failure, if your mitral valve area is less than 1, you fall into that severe range. Half of pregnant patients will run into heart failure, and about a third will run into heart failure with a mitral valve area less than 1.5. And various references I looked at said that, I know for the most part we use the continuity equation for calculating the mitral valve area, but this tends to actually be improved more accurate in pregnancy compared to the Doppler pressure half time. In terms of medical therapy, so beta blockade is really important for these patients, especially if they have symptoms, or they have high RVSP. Really slowing down the heart, improving the diastolic filling time is very important. Diuretics can be used if they're refractory, but again, cautious use, in conjunction with their obstetrician and monitoring of the fetus. And then if they have, atrial fibrillation, anticoagulation can be considered. And there is some thought, though no formal recommendations, for patients who are in sinus and they have very high risk features such as smoke in the left atrium, a volume index greater than 60, or clinically have heart failure, maybe these patients should be anticoagulated. It's come up in a few review articles that I've seen, but I haven't seen a formal recommendation on this. And then balloon valvuloplasty can be considered or should be recommended in patients who have severe mitral stenosis prior to becoming pregnant. And then it should be considered if patients are pregnant and have severe symptoms or high RVSP despite medical management. Just a contrast with regurgitant lesions using mitral valve prolapse, which may come with differing degrees of insufficiency. Mitral valve prolapse is the second most common valvular disease of pregnancy, which can have various etiologies: rheumatic, myxomatous, ischemic. These lesions tend to be well tolerated. While the increase in blood volume could increase regurgitation, the decrease in systemic resistance and afterload tends to lessen regurgitation. So they tend to kind of offset each other, and regurgitant lesions for the most part are tolerated in pregnancy. Serial echoes should be considered in each of the trimesters. I wasn't able to find any hard recommendations on this, but in a patient with mitral valve prolapse, it's not unreasonable to do an echo in each trimester. If they have, more severe MR, then doing it more frequently. And for the most part, these patients can be observed, but if they run into issues with volume, diuretics could be considered. Now, aortopathies is a common topic in the pregnant patient. In aortic dissection, it's rare, but it's a devastating event. And just due to the increased hemodynamics of pregnancy, I have this figure here of a very pulsatile aorta in a pregnant patient. Due to the increased cardiac output, the increased heart rate, increased stress is provided on the aorta and would increase the risk of aortic dissection. And in fact, aortic dissection was about 4 times more common in patients who are pregnant compared to the non-pregnant patients. These events are very, very rare overall, but occur more commonly in pregnancy, especially if a patient has an underlying aortopathy. And the risk tends to occur, as they pass that, as they enter the second trimester, and there is some residual risk in the postpartum setting due to the resolving hemodynamics of pregnancy. So I really like this table from the ESC guidelines that goes through the various aortopathies. Marfan's, Loeys-Dietz, Turner, and then vascular Ehlers-Danlos, the vascular type 4 tend to be of your highest risk for aortic dissection in pregnancy. Vascular Ehlers-Danlos is in particular very high, and is the advice for these patients is to not become pregnant at all if possible. Various parameters can be used to help guidance in terms of pre-pregnancy counseling. So an ascending aorta greater than 45 or greater than 40 millimeters in the event of family history in a patient who has Marfan's disease, these patients should be advised to not become pregnant. Bicuspid aortic valve is a much lower risk of having an aortic dissection, and so an ascending aorta greater than 50 is the cutoff that's used here. Turner syndrome, you'll note that the aortic size index is indexed here. These patients tend to, because of their genetic condition, tend to be of lower stature. So this value is indexed, and 25 I think is helpful to know. And in terms of monitoring, an echo at 12 weeks and then every 4 to 12 weeks based on the risk is what's recommended in the ESC guidelines. So for example, if they have a high risk lesion like Marfan's, it would be reasonable to echo them every 4 weeks, but a patient with bicuspid aortic valve, 12 weeks is reasonable for them. In terms of prevention of aortic dissection in pregnancy, strict blood pressure control is what's needed, and I couldn't find specific numbers in terms of what's a target with these patients. Certainly there are targets for hypertension in pregnancy. I couldn't find anything specific from there, but beta blockade is generally what's recommended. Labetalol is safe, reduces heart rate and blood pressure. The treatment, if one does unfortunately have an aortic dissection, emergent surgery is what's recommended in type A, and conservative management can be recommended in type B, is what's recommended in the non-pregnant patient. And fetal mortality tends to be high in type A, it's 20 to 30%. Proceeding with surgery while the fetus is still in utero should be considered, but may not be possible depending on the center. And then in terms of aortic dilation, in a patient who has an ascending aorta, 40 to 45 millimeters, continuing beta blockade having regional anesthesia to reduce that sympathetic drive and cardiac output. Vaginal delivery is actually reasonable in these scenarios, but in individuals with an aortic diameter greater than 45 millimeters, or EDS type 4 if they became pregnant, or have an acute or chronic dissection, as a controlled environment as possible with cesarean section is what should be considered. Now, I'm aware of the time, so I won't get into preeclampsia. I'll just kind of skip ahead a little bit, I apologize. But essentially, there was a study that looked at speckle tracking echocardiography in patients who had severe preeclampsia, who had to deliver less than 34 weeks. And what they found is that, you know, as we talked about before, strain tends to be reduced in pregnancy but recovers in the postpartum period. But the women who had severe preeclampsia tended to not recover this reduced strain. And so, you know, additional techniques like speckle tracking echocardiography may be useful in you know, detecting subclinical systolic dysfunction, and it may be why these patients are vulnerable to cardiac disease in the future. But again, this is all still very early work. So just talk briefly about preconception counseling. The WHO risk classes can be utilized to help put patients in various risk categories depending on their pre-existing cardiac condition. So these are helpful references to keep in mind when counseling these patients. The risk class 3, which includes mechanical valves, cyanotic heart disease that's unrepaired, Fontan circulation, the aortic dimensions that we talked about, these patients are at significantly increased risk. These patients should have expert counseling, and if they do become pregnant, be monitored appropriately. And these are various conditions. The risk class 4 is generally where pregnancy is contraindicated. The CARPREG study is the last thing I will just briefly mention. This is a study, you know, produced by our own Toronto group that looked at pregnancy outcomes in women. And what they did is they looked at 1,900 pregnancies, mostly in patients with congenital heart disease, about 63%, but some had acquired heart disease, mainly heart failure or arrhythmias. And what they looked at is the adverse events in this patient population. This was a patient population, I believe, from 1994 to 2012. And they found that there was about 307 adverse events. They tended to be mainly heart failure or arrhythmias that occurred in pregnancy. Dissection, you can see, was 0.4%, but this is obviously much higher than the general population risk, and it's quite high overall. And what they did was they looked at predictors in terms of what could predict an adverse event, and then they assigned various weightings and scores to them. And so the CARPREG score is something that could be used to help assess risk for patients, prior cardiac events or arrhythmias, baseline high symptom burden, mechanical valves, LV dysfunction. These all tended to have higher risk, and a score greater than 4, or even scores greater of 4, 3 or 4, should require consideration or prompt consideration of referral to a high-risk center. And just a plug for the cardio-obstetrics team, is really collaborative work between the cardiologist, obstetrician, anesthesiologist, nursing, pharmacy, to help deliver care for these patients. So to summarize, pregnancy is associated with multiple physiologic changes, including increases in heart rate, cardiac output, total blood volume, decreased systemic vascular resistance, and this affects what we see on echo. You may see mild chamber dilation. You may see increased physiologic valve regurgitation. Systolic and diastolic function are likely preserved, and these parameters tend to normalize within the weeks postpartum. Peripartum cardiomyopathy tends to be dilated cardiomyopathy, where an EF less than 30% or an end-diastolic dimension of the LV greater than 6 portend a worse prognosis, and lack of recovery has a high risk of mortality in future pregnancies. Stenotic lesions are poorly tolerated in pregnancy, while regurgitant lesions are better tolerated. Aortopathies carry varying risks of aortic dissection, require monitoring pregnancy with serial echoes. And then WHO classes or CARPREG can be used for pre-pregnancy counseling. These are my references. I'm happy to share any articles and happy to answer any questions.
So very nice.
Hi, Mike.
Hi.
Is it safe to use any ultrasound enhancing agent in the pregnant patient?
Yeah, it's a great question, and one that I tried to look into. Unfortunately, the you know, the ones that we use, the lipid Definity, have not been studied or used in the pregnant population. So the recommendation from the manufacturers is to not use them unless absolutely necessary. So we don't have data in that regard. Agitated saline is generally considered to be okay, but the contrast enhancing agents, we just don't have data for it, unfortunately.
We happen to have some local expert in contrast, and like Dr. Leon Poi, as well as vendors from Definity. Maybe they can comment on it as well. I'm curious about what they would say. Maybe Jeff, or do you have any comments on that from Definity's point of view? Or Howard?
Yeah, so I think Mike summarized it well. Actually, I think we just don't have data to support it. From a theoretical standpoint, there should not be a reason why you could not use it. The microbubbles shouldn't cross the placental barrier. But you know, so I think in select circumstances where you don't have, where it's maybe potentially a life-threatening condition, and you're limited to echocardiography as your own only imaging technique, then from a risk-benefit standpoint, it may justify use. But without that, we don't use in the lab.
And what do you think about saline contrast?
Yeah, so we've looked at this, and others have, and we've performed saline contrast with pregnancy before, and so as Mike said, I don't think there's a contraindication, and so we don't see it as a contraindication in our lab.
Yeah. So Martin came back in the comments to say that we should refer to the product monograph, which is very reasonable, and I think Mike has summarized that very well. Fortunately, most of the pregnant women in general are very echogenic, so we haven't really run into that problem that much, so thank God. And I think, you know, use it wisely. Okay, any other question? I think Dr. Kumar made a very interesting observation. He said in the comments, MVP, mitral prolapse, tends to disappear in pregnancy if mild, but if chamber dilates, the MR will worsen. Please comment.
Yeah, no, I totally agree, and it makes sense in terms of, you know, if the chambers dilate, malcoaptation can occur, and you know, this can certainly worsen the degree of regurgitation. So I agree, that makes sense to me.
Yeah, I think the idea of mitral prolapse is like, you know, the leaflets are actually subtended by the papillary muscle. When the ventricle dilates a little bit, what happens is that the papillary muscle also displays from the centroid, and thus, you know, pulling up the leaflet back into the ventricle. So it's not infrequent that we see that phenomenon when people have dilated cardiomyopathy. Like we actually compare echoes before, like, you know, we'll say, well, patients before have mitral prolapse, and now they've dilated cardiomyopathy for whatever reason, either ischemic, non-ischemic, and sometimes with pregnancy, the little bit of LV dilatation, we actually reversed the mitral prolapse and the degree of prolapse across the annulus. So yes, that's actually all geometrical. Okay, any other comments? We have about 4 minutes to go before 9 o'clock. Great summary, great presentation. Thank you. And for the residents and fellows, this is a common topic in your Royal College exam. For some reason, every single year has some. About all the physiological changes in pregnancy or associated with pregnancy. Okay, so without further ado and other further questions, I want to thank Mike for his excellent presentation, and want to wish you all well, and hopefully all your snow has been dumped out and can travel back safely. And nice weather outside in Toronto today, so lots of sun. So go out and, you know, have some sun. Okay, take care, everyone.
Thank you.